Hi everybody. Today we're going to be talking about euthanasia. I have two videos for you on this. This first one that you're starting with now is just looking at some of the basic terms and concepts that we're going to talk about, as well as some foundational cases. And then for the second video, we'll get into some of the commentary and critique of some of the main approaches to how to think about the morality of euthanasia that you have in your textbook. So just to define our terms, first of all, euthanasia is a word that comes from Greek. The prefix EU, just means good. So we already saw that in another Greek word, eudaimonia, which we saw translates into a good life or a life well lived. And then euthanasia, the second part of that word, thanatos, means death. So literal translation into English of this word means a good death. And so usually when we think about euthanasia, the term itself is predicated on the idea that the intention behind it may be to cause or to create a good circumstance for death. So the moral debate is going to be whether there can actually be a good death, and if so, under what circumstances are we allowed to facilitate that. We're also going to talk about some foundational cases in the United States that help to inform the American Medical Association's policy on euthanasia. So from left to right, we have Karen Ann Quinlan. Quinlan was a young woman who, at the age of 21, went into what we call a persistent vegetative state, which is a state of permanent unconsciousness. She was hooked up to a machine called a ventilator. And in 1975, her parents were fighting to have her removed from that ventilator on the grounds that it was only prolonging her life, but that she would never regain consciousness or get better. The middle figure here is a woman named Nancy Cruzan. Her case occurred in the early 1990s, and the question there was whether what's called artificial nutrition and hydration could be removed. Artificial nutrition and hydration is a feeding tube, usually inserted directly into the stomach, and then IV fluids through a needle in the arm or somewhere else. And probably most famously, the one of these that you are most likely to have heard of is the woman on the right. That's Terri Schiavo. And her case was debated very hotly in the United States in 2005. There was a big debate between her husband, Michael Schiavo, and her parents about what her exact diagnosis was and whether they could discontinue treatment. The U.S. politicians even got involved in that one. So we'll talk about these and the way that they've influenced the current debate on euthanasia, not just in the United States, but worldwide as well. So to tell you a little bit more about the Quinlan case, what's remarkable about this case and what about it led to institutions like the American Medical Association making policies is that it just happened to occur at the right place at the right time with some unusual characteristics. So first of all, we've got a case of a young woman. I mentioned that Quinlan was 21 years old when she entered this state of permanent unconsciousness. What happened to her was that she was consuming alcohol and some drugs and had a very low body weight. She was probably anorexic. And this combination of factors caused her to fall into a permanent coma. As a result of that, she was dependent on a ventilator for breathing. So I'll show you an image of a ventilator machine in a few minutes. But basically, the ventilator is a machine that was developed in the late 1960s and was used to help patients who couldn't breathe on their own continue to breathe so that the medical team could stabilize them. So this ventilator was still pretty new technology during the time of Karen Ann Quinlan's case. And this was the first case where people really challenged the idea of putting a patient on a ventilator indefinitely. In other words, not as a temporary stopgap measure to use for a little bit until that person could breathe on their own and recover, but as something that you would have to have them on for the duration of their life because they actually lost the ability to breathe on their own. So the question here was whether this patient, Quinlan, could be removed from life-prolonging equipment, in this case, the ventilator. Her parents were petitioning to have her removed from this equipment. This was New Jersey, the state of New Jersey in the U.S. in the 1970s. And part of the problem was that she was being held in a Catholic hospital that had a policy against doing anything that they took to be hastening death or causing death. So the big debate occurred when the parents requested that she be removed and the hospital said no, and that's how it went all the way through the court system. So here's an image of a patient on a ventilator. Usually you see these all the time in medical dramas on TV. They're often used in trauma situations, again, to stabilize patients. And this was a big issue because prior to the development of the ventilator in the late 1960s, If a patient stopped breathing, that was simply it. We didn't have a way other than through chest compressions and other sort of more hands-on methods to get them to continue breathing. So the ventilator was a huge step that in which a tube is inserted through the mouth into the windpipe, and it basically does the work of the lungs for you for a certain period of time. So this was, as I said, never intended to be a long-term, lifelong piece of equipment or procedure for somebody. It was developed as a short-term life-saving device that the patient would then be removed from. So when the ventilator was developed, that was when we really had to start thinking about the point in time in which it's okay to remove life-saving equipment like this from patients who are not likely to recover normal functioning or really any functioning at all in the case of Karen Ann Quinlan. So Quinlan and the other two women whose images I showed you, Nancy Cruzan and Terry Schiavo, were all in a state that we call a persistent or permanent vegetative state. This is a state in which it's different than a coma. When we say someone's in a coma, we just mean that they're unconscious. And we often hear stories about people waking up from comas after very long periods of time, even pretty frequently. So it's very clear to understand that when we're talking about this diagnosis of persistent or permanent vegetative state, like Karen Ann Quinlan was in, like Terry Schiavo was in, and like Nancy Cruzan was in, there's no possibility of recovery. The reason for that is that the brain, the higher brain, basically everything contained in your cranium, has completely stopped functioning. That's everything that controls consciousness, awareness, cognition, and intentional action. What is functioning to some extent for patients in persistent vegetative state is what we call the brain stem. That's the part that starts right about here. The brain stem controls all the things that we do without thinking, like breathing sometimes. Sometimes people in a persistent vegetative state can breathe on their own. Sometimes they can't. Metabolizing nutrients, circulating blood, all of that good stuff are things that we don't have to consciously think about, that our bodies just kind of do on their own, part of the sort of automatic part of our nervous system. So people in persistent vegetative states will still go through what's called a sleep-wake cycle. And what that means is sometimes your eyes are open and sometimes your eyes are closed. They also might be able to breathe on their own. As I said, it kind of depends on the type of injuries and the diagnosis that we're talking about. So because of some of them can breathe on their own, and because most people go through this sleep-wake cycle where their eyes are open some of the time, a lot of people have a hard time accepting and understanding that the patient is not actually conscious, even though their eyes are open. That's going to lead to a lot of the controversy, especially when we're talking about the Terry Schiavo case, which we'll get to in more detail a little bit later. So another important thing to keep in mind is that euthanasia is not the same as physician-assisted suicide. So what we're talking about today in this section is just exclusively euthanasia. In euthanasia, we have a patient who is probably not able to choose or take action regarding his or her own life, his or her own medical care on their own. They're usually unconscious or so severely impaired that they're not able to do things for themselves, and they certainly wouldn't be able to take action on their own part to walk out of a hospital or get away from unwanted medical treatment. So usually when we're talking about euthanasia, we've got someone whose interests have been expressed before, and we're following those, or someone who has what we call a surrogate decision maker, a friend or family member who's been designated to make decisions for them. So when we're talking about euthanasia, we're talking about a severely compromised patient, and another person, a doctor or a nurse, would remove life support, as one example, in order, with the result of hastening death, of making death happen more quickly. Assisted suicide is very different. In assisted suicide, this is something that the patient requests, and the patient has to be rational and autonomous in order to request that. And the patient is taking action to cause his or her own death. So usually the way this works is the patient is prescribed or given a very high dose of something like morphine and told how to use it in order to end their own life. And this is legal in some states in the United States. The states in which it is legal is only allowed to be used by people who are diagnosed with terminal illness. In other words, they have an illness that will kill them and that they can't be cured of. So we're not talking about assisted suicide today. We are just talking about euthanasia, where we're talking about a patient who can't take action for themselves, and medical professionals and others are trying to decide whether to continue treatment or whether to start treatment. So there are some different types of euthanasia and some important distinctions that we're going to have to make in order to really understand James Rachel's argument against it and Bonnie Steinbach, the second author, her arguments about it as well. First, we have the distinction between voluntary, non-voluntary, and an involuntary euthanasia. Voluntary euthanasia has been requested by the patient. And you may be saying, well, wait, you just said the patient's usually unconscious. Well, in the United States and in other places, we have living wills and we have things called advance directives. These are both legal documents that will allow you, while you are conscious, rational, and autonomous, to designate circumstances in which you would not want treatment to continue. So that's the sense in which you can have a patient who is currently not able to express their wishes. You might still have a document in which that person expressed their wishes at some point in the past. Non-voluntary euthanasia would be a situation where you don't know what the patient's wishes are. So non-voluntary euthanasia just means that they haven't explicitly said, and you're having to make an educated guess in some way about what is appropriate for them and what they would want. This, however, is different from involuntary euthanasia. I have to say, involuntary euthanasia almost never happens, and if it did, it would be both unethical and illegal, regardless of whatever other laws are in place about euthanasia. So the only reason I bring it up here is that so we know that non-voluntary euthanasia is not something that's done against the patient's wishes. Non-voluntary is done when we don't know what the patient's wishes are and we have to guess. Involuntary euthanasia, which would be very, very bad, would be if the patient said, no, I want to live, and we euthanize them anyway. So involuntary euthanasia is something that we don't really even have on the table as a moral issue because there's almost universal agreement that it is morally wrong. So what we're really talking about today is these other two types. Another distinction that we need to make that's going to be very relevant to the James Rachel's reading is the distinction between active and passive euthanasia. So when we're talking about what's called active euthanasia, we're talking about someone taking a direct action to cause the patient's death. The practice of lethal injection as a punishment for, in capital punishment as a death penalty is a great example of this. Obviously, if we're talking about very sick patients in a hospital, we're not talking about the death penalty. But very similar course of action might be taken if I was to intentionally administer a very high dose of medicine because I want to cause the patient's death. That's called active euthanasia. This is almost universally prohibited. The American Medical Association, which is the main governing body for all American doctors in the United States, prohibits active euthanasia. They do allow this second type called passive euthanasia. And passive euthanasia, you're not intentionally doing something to a patient that is designed to cause their death. What we call passive euthanasia is this idea that you're just not going to start a life-saving or life-sustaining treatment, or you would remove or withdraw a treatment that is keeping a patient alive. And the idea here, the reason why it's called passive euthanasia, is that your action is not directly causing the patient's death in this situation. You're removing something that was keeping the patient alive, but the rationale is that the patient's underlying illness or condition is really what's causing them to die once that life-sustaining treatment is removed. So as I said, the American Medical Association finds this to be a very important distinction to make. They do allow with removing or withdrawing life-sustaining treatment under a lot of circumstances, but they do not allow active euthanasia, which is intentionally doing something to the patient to hasten death. So in the American Medical Association's Code of Ethics, they first formulated a statement on this topic in 1975. Now you've heard that year once before in this video already, because that was also the year that Karen Ann Quinlan's case was decided. So Karen Ann Quinlan's case was actually the motivation for the American Medical Association to finally put forth a policy on this topic. Again, prior to the development of medical technologies like the ventilator, there was no real need for this because we didn't have the ability to keep people alive under these circumstances. With this new technology, now we have a new area of ethics that we have to try to figure out. So in this 1975 statement by the AMA, passive euthanasia is allowed, and this is described as letting the patient die. But active euthanasia was prohibited, and it was described as deliberately killing the patient. So we've obviously come quite a long way since 1975. It is 40 years later now. So I just want to show you that the American Medical Association's position today has not really changed. They have changed the terminology, and they have elaborated on this policy. So what you see here, if you go to the American Medical Association website, you can find this. This is the statement supporting that you can, as a doctor, withhold or withdraw life-sustaining medical treatment. And they're claiming this as a way of supporting patient autonomy and honoring previously made requests and decisions, values that patient upheld in the past. So it says here there's no ethical distinction between withdrawing and withholding life-sustaining treatment. A competent adult patient may in advance formulate and provide a valid consent to withholding or withdrawing life support systems in the event that injury or illness renders that individual incompetent. They may also appoint a surrogate decision maker. So all of this is saying patients can say ahead of time, or a surrogate decision maker, another person who's deciding for the patient, can request to withhold or withdraw treatment, and the doctor can comply. According to the AMA, there's nothing unprofessional or unethical about that. They are not calling this euthanasia anymore, though. They are just calling it withholding or withdrawing treatment. Today, they define euthanasia exclusively as active euthanasia, and they prohibit that. So euthanasia, they say, is the administration of a lethal agent by another person to a patient for the purpose of relieving the patient's intolerable and incurable suffering. So what we have here is a prohibition, again, of what we're calling active euthanasia. The idea that you can intentionally end a person's life by administering what they call a lethal agent, something that will, in fact, kill them. So what you have here, and you only have a screenshot, if you want to go to the website, you can read a little bit more, a recognition that this is something that you might be inclined to do out of compassion, but something that we don't want physicians to do, according to the American Medical Association. So for the ethics of euthanasia, one thing that we have to keep in mind is that professional codes of ethics are not necessarily authoritative. So think back to the beginning of the class when we talked about the distinction between, for example, ethics and the law. We've talked a lot, especially with Kant, about whether your ethics depend on your job. So we have professional codes of ethics that are intended to be used as a moral guide for physicians and others. But we also know that we can't just look at this list of rules and say, well, that must also be what's morally right. So we need to take a step back and say, yes, this is what the Professional Code of Ethics says, but what's the reasoning behind that? Why does the American Medical Association hold this view? And do we find that stance reasonable? Not because it's what they say, but because of the reasons behind what they say. So our question is going to be, moving forward, does the American Medical Association stance hold up to ethical scrutiny? That's what the authors James Rachel and Bonnie Steinbach are going to be investigating, and what we'll look at in our next video.